Hello everyone, this is Chadi Alraies from CVI in Denver, Colorado. I'm really privileged again to be with Dr. Maheedhar Gedela. He is an interventional cardiologist now. We're going to be practicing interventional as well as structural heart disease. Maheedhar, always nice to see you.
Yeah, it's always great to see you, Chadi. Yeah.
And this is your third or fourth CVI?
This is my third, but I attended all of them since 2018, since the COVID 2 years.
So that speaks a lot about the quality of the meeting, and you liked it, and your engagement as well.
Yeah, absolutely. Yeah, it's like a great meeting, and then everybody here is very approachable. So that's what I like about this conference. Yeah.
So you're presenting a challenging case in the structural heart, which is your passion.
Yeah.
About a redo.
Yeah.
MitralClip. I heard a redo TAVR.
Yeah.
But I never heard a redo MitralClip.
Yeah.
So tell us a little bit how this case is changing.
Yeah, definitely. I want to tell first, when I first came to this conference in 2019, I also presented the MitralClip case at the time during my general cardiology fellowship time. Yeah, and then now I'm presenting this case. This is during the structural era of training that we did this case at Mount Sinai Hospital. So the case is about an elderly woman who had MitralClip that was done at an outside institution. And the patient had afterwards recurrent acute heart failure exacerbations. And then we looked at the TEE, and the TEE, it was shown that the clip was not entirely attached to the posterior mitral leaflet. The part of the clip was attaching to the caudal leaflet tissue. And also there was a leaflet perforation medial to the previously placed clip. And there is an additional jet, lateral to the previously placed clip. So we thought the pathology is mainly the clip, the jet coming lateral to the previously placed clip. That's why we thought the patient would benefit from MitralClip evaluation after we had an extensive heart team discussion, because the patient was extremely frail and then multiple comorbidities, so not a candidate for
heart failure symptoms.
Yeah, and also please go ahead.
So before you continue with the intervention, what was the timeline between the first clip and coming to you, and why the implanter who did it in an outside hospital, they didn't notice that there is no improvement in the jet?
Yeah, we don't have those TE films in post-procedure. Actually, that clip was done in June 2021, and she was seen at the institution where I did my fellowship. That was around in September, and at the time the patient presented with heart failure exacerbation. So, and then the case was presented to the surgeons, and because of her again comorbidities and frailty, it was not deemed a candidate for open heart surgery, and moreover that the patient had a prior bypass surgery and the grafts were patent. Again, that adds to the complexity in terms of the triaging the patient, whether surgery versus percutaneous.
Awesome. So, and then she was turned down by surgery, came back to you.
Came back to us.
What would be your approach for a redo clip? Is there something else you should do, any different measurements or evaluation?
Yeah, definitely. Again, it starts with how the mechanism is. So it's obviously there is, the approach is different from primary mitral regurgitation versus secondary mitral regurgitation, because for the primary mitral regurgitation, especially the patient which we were dealing with the transeptal height and also the type of the clip that you have to use entirely different. And also in secondary mitral regurgitation, the EF is most of the times it's down. However, in the atrial functional MR, the EF may be preserved. Then the clip strategy would be different. And whether it is one clip versus two clips, it depends on the pathology as well. Most of the times for the secondary MRs, we tend to do two clips. The first clip being the second clip being to stabilize the first clip, and in case if it's primary mitral regurgitation, if there is a severe mitral valve prolapse, which was not in our case, in those cases also depending on the jet, we might start with one clip, and if the gradients are acceptable, then we'll place the second clip to achieve the best possible results.
And in this case, how many clips did the patient receive?
So the patient previously had one clip. So now we thought we can deal the pathology lateral to the clip with one clip, so which we intended before going to the procedure. So, and then at the end of the case, one clip did the job for us in reducing the mitral regurgitation from severe to moderate. And the patient still has there is a jet that was mainly coming from the perforation, which is not advisable to do transcatheter therapies to treat that perforation. But the patient was seen in the clinic at 30 days, and the patient's heart failure symptoms improved much better, and she didn't have come to the hospital often, because in fact she did have a Pleurex catheter placed because of the pleural effusion. So now the Pleurex catheter was removed, and the patient did amazing.
Right. And will be your follow-up for this patient? Will you do a serial echoes or TEEs to evaluate that clip?
Yeah, so it depends on the patient's symptoms. Again, if the patient is the symptoms are stable, we usually do at 30 days the post transthoracic echocardiogram. We don't need to do the transesophageal echocardiogram. And also after 1 year, we again see the patient in the clinic, and then we do the echocardiogram at the time. So if the gradients are stable, then we can see the patient every year.
Management, huh? Yeah. Well, very challenging for sure. I'm looking forward for to seeing the slide as well.
Yeah, definitely.
Thank you for always being present at CVI, and you'll become very implemented in the program.
Yeah.
Please watch these videos and others on the CVI YouTube channel. This is Chadi Alraies from Denver, Colorado. Maheedhar, thank you so much.
Yeah, thank you so much again, Chadi. Yeah, it was great seeing you.